Alors, bonjour tout le monde. Malheureusement, on commence un petit peu en retard, mais on va essayer de suivre notre agenda. Bonjour et bienvenue à la 22e réunion du Comité permanent des Affaires autochtones et du Nord. We're gathered here today on the unceded territory of the Algonquin Anishinaabe Nation. Today, we'll spend the first hour hearing from our last witnesses on the NIHB study and spend about 30 minutes on drafting instructions for that report. We'll also consider the second version of our draft housing report, which was circulated last week. Last but not least, we'll consider the travel budget for our Arctic Sovereignty, Security, and Emergency Preparedness study for the fall. If we're all in agreement, we'll instruct the clerk to submit that to the Liaison Committee. Aujourd'hui, on termine notre troisième étude sur l'administration et l'accessibilité des peuples autochtones au programme des services de santé non assurés. On today's panel, we will be hearing from Lee Allison Clark, Manager, Policy and Research, Native Women's Association of Canada, who's with us in person, Joy Eadlaut, as an individual, and Grand Chief Jerry Daniels, Southern Chiefs Organization, also as an individual. Et je voudrais rappeler
And I'd like to remind everyone of the requirements of the Board of Internal Economy concerning physical distancing and wearing masks.
I'd like to outline a few rules to follow. Members or witnesses may speak in the official language of their choice. Interpretation services in English, French, and Inuktitut are available for the first part of today's meeting. Please be patient with the interpretation. There could be a bit of a delay, especially since Inuktitut has to be translated into English first before it can be translated into French and vice versa. The interpretation button is found at the bottom of your screen in either English or French or Inuktitut. If interpretation is lost, please let us know. We'll pause and try to fix that problem. The raise hand feature at the bottom of the screen can be used at any time if you wish to speak or alert the chair. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. For those in the room, your microphone will be controlled as normal by the Proceedings and Verification Officer. When speaking, please speak slowly and clearly, and when you are not speaking, your mic should be on mute. A reminder that all comments should be addressed through the chair. So the way we do this is each of the witnesses will be invited to speak for 5 minutes, and I would ask you to respect that 5 minutes, after which we will have a question period. So thank you to the witnesses who are appearing today. We will now proceed, and I will begin by asking Ms. Clark to start. Ms. Clark, you have 5 minutes.
Do I have to press the button? Great, thank you. Good afternoon, bonjour, honorable members. Thank you for the invitation to come here today to speak to the administration and accessibility of Indigenous peoples to the non-insured health benefits program on behalf of the Native Women's Association of Canada. I want to acknowledge that the land that I and others are on here today is that of the traditional and unceded territory of the Algonquin Anishinaabe people. As you all likely know, NWAC is a national Indigenous organization representing Indigenous women, girls, Two-Spirit, transgender, and gender diverse people in Canada. And as we all know, accessibility, availability, and acceptability of health services indirectly and directly impact Indigenous people's health and health outcomes. Although the NIHB program provides critical financial support for accessing services, more must be done to ensure Indigenous women, girls, Two-Spirit, transgender, and gender diverse people have access to essential healthcare services that are acceptable, culturally and gender sensitive, and trauma informed. The NIHB program represents a lifeline for Indigenous people. Indigenous women utilize the NIHB at higher rates than Indigenous men. Previous amendments to the Indian Act have meant that a greater number of individuals can claim or restore their status. Bill C-3, the Gender Equity in Indian Registration Act, and Bill S-3 aim to eliminate known sex-based inequities in registration. Because of this, many people became entitled to register under the Indian Act. Understanding that the population with access to NIHB has significantly grown in the past years, with a vast amount of the growth occurring in small and remote communities. NWAC really welcomes discussions on ways to better this. Today, I will highlight several scenarios that underscore where the NIHB falls short and welcome discussions throughout the hour to provide tangible solutions to these shortcomings. The examples I will present in the next few minutes just represent the tip of the iceberg. In nearly every sharing circle, focus group, or engagement session focusing on healthcare experiences that NWAC has held with Indigenous women, girls, Two-Spirit, and gender diverse people, difficulty in accessing services, the availability of services, and the quality of services, and experiences of discrimination, racism, and sexism are raised. Whether straightforward racism or discrimination embedded in institutions, healthcare services are often inaccessible to the folks who need them most. As with many other countries worldwide, women typically have higher prescription rates than men. This also is true in Canada. This also remains true for Indigenous women when compared to their male Indigenous counterparts and the Canadian population overall. Therefore, the NAHB remains critical for Indigenous women to survive and is a gendered issue. However, the NAHB drug coverage plan, as continually highlighted by the Canadian Pharmacists Association and others, provides less drug coverage than the average Canadian receives. When we consider Indigenous women, girls, Two-Spirit, transgender, and gender diverse people encounter one of the highest disproportionate burdens of health disparities in Canada, which stem from various determinants of health, this can be catastrophic. Access to birthing services close to home is something Canadians expect. This is not the case for Indigenous pregnant people. A recent study published in the Canadian Medical Association Journal found that Indigenous pregnant people in Canada experience striking inequalities in access to birth close to home when compared with non-Indigenous folks. Although the NAHB covers many of the expenses associated with travel for pregnancy, it is limited to one pregnant person and the addition of another person as of 2017. However, often this other person is a doula or a midwife and not family or friends. Children are left behind. This is problematic. Birthing on or near traditional territories and in the presence of family and community is a long-standing practice of foundational cultural and social importance that contributes to overall maternal and infant well-being amongst Indigenous people. It gives them a good start. Most Canadians have the luxury of giving birth near their home with their partner in the room or perhaps their family in the waiting room. NAHB just simply not allow for this, creating a standard for Indigenous birthing people less than that of the Canadian population. Layers of racism and sexism continue when you consider dental care for Indigenous women, girls, Two-Spirit, transgender, and gender diverse people. Wearing dentures, receiving off-reserve dental care, asking to pay for dental services, perceiving the need for preventative care, flossing more than once a day, having fewer than 21 natural teeth, fear of going to the dentist, never receiving orthodontic treatment, and perceived impact of oral conditions on quality of life all have been correlated with experiencing a racist event at the dentist. Simple tasks many Canadians take for granted, like getting their teeth cleaned, become a potentially traumatic event for Indigenous folks. This doesn't even begin to tackle the layers of issues rife within finding access and getting to the dentist. Before contact with European settlers, First Nations and Inuit healers bore the responsibility of health for their people and relied upon a rich body of knowledge for traditional medicines and sociocultural practices. The administration of the NIHB program must integrate this and be culturally and gender sensitive as well as gender informed if we are ever to fully walk the path of reconciliation. However, respecting the Ottawa Charter for Health Promotion, which was developed in 1986, so many years ago, and as outlined by FAC, reductions in health inequities require reductions in material and social inequities. When considering the NIHB, this means increasing coverage of, easing access to, and increasing the availability of preventative, allopathic, and traditional medicine. In sum, we cannot risk any more Indigenous women, girls, Two-Spirit, transgender, and gender diverse people falling through the cracks when looking to access the care they have a right to. NWAC wants to be part of the solution for how best to increase accessibility and better the administration of the NAHB program. I look forward to presenting some more detailed recommendations throughout the hour. Thank you, Mgretch.
Thank you very much, Ms. Clark. We'll now go to Ms. Idlout. Ms. Idlout, you have the floor for 5 minutes.
Do I start now?
Yes, please.
Sorry. I believe it would be better for people that escort to start getting paid, as going out of town for medical is really stressful. Having to leave your children at home with someone and then being in a different city, having to remember appointments, taking them to their appointments, preparing for surgery or anything that's required. It takes a lot on you, especially when you're escorting an elder. Sorry, I didn't really have much time to prepare for what I'd say.
If you wish, Ms. Seidlout, we can leave it to when questions are asked, and perhaps at that point you can answer, unless you want to speak. If you have some other things to say, you still have 3 minutes.
I'd prefer questions.
Very good. So we'll get back to you with the questions. We'll now turn to Mr. Jerry Daniels, Grand Chief, and Grand Chief, you have the floor for 5 minutes. Grand Chief, you're muted, so we can't hear you. You're still showing as muted. We can't hear you. So there you go. Go ahead now. I think we hear you now.
Thank you. I would like to begin by acknowledging that I'm joining you from Winnipeg on Treaty 1 territory, also the unceded lands of the Dakota. I want to take a moment to acknowledge our elders, who are the keepers of our knowledge and culture and who face significant barriers when attempting to access non-insured health benefits. I want to thank the Standing Committee for the invitation to appear today. Right now, there is a documented 11-year gap in life expectancy between First Nations people and all others living in Manitoba, and that gap is growing. I want to remind the Standing Committee that Canada has a responsibility to provide equitable health services to First Nation citizens. According to Article 25 of the United Nations Declaration on the Rights of Indigenous Peoples, Indigenous peoples have an equal right to the enjoyment of the highest attainable standard of physical mental health, and states shall take the necessary steps with a view of achieving progressively the full realization of that right. First Nations also have inherent Aboriginal and treaty rights under Section 35 of the Constitution Act of 1982, including the right to health and self-determination over health systems. Treaties affirmed First Nations jurisdiction over our health systems and established the Crown's obligation to provide medicines and protection. Due to the existing crisis in healthcare for First Nations, the Southern Chiefs Organization is actively leading a health transformation process following the signing of an MOU with Canada in June of 2020. Our community engagement process has included input on non-insured health benefit programs and services. The NIHB program has been identified as one of the most significant concerns in its aspects, as it impacts every First Nation citizen, from our children and youth through to our elders, both on and off reserve. The current NIHB services are some of the biggest barriers to positive health outcomes for First Nation citizens. The administration of the program and the inconsistent application of the program policy results in citizens receiving substandard services or being denied care outright. I cannot state strongly enough that our citizens told us that every component of the NIHB program does not meet their needs. For instance, 61% of Southern First Nations citizens have a drive time of between 1 and 3 hours to get to from their nation to the nearest hospital or pharmacy. The biggest barrier in getting to the hospital or pharmacy is the denial of services by NIHB for medical transportation. Let's stop and think for a moment about having to seek permission every time you need to get to the hospital or a pharmacy. Even when transportation is approved, NIHB medical transportation rates, including mileage and meals, sit well below the rates provided in other areas, other programs. Veteran Affairs, for example. The current NIHB medical transportation private vehicle mileage reimbursement rate in Manitoba is 21.5 cents per kilometer. Veteran Affairs is almost double the rate at 49.5 cents per kilometer. The current NIHB meal allowance rates for our citizens is set at 48 per day, where Veterans Affairs is 93.5. When traveling to larger urban areas for medical appointments that are not available on reserve, the commercial accommodation rates are not high enough to ensure the safety and comfort of our citizens. Accommodations in Manitoba are at a maximum of 120 per night, whereas with Veteran Affairs, it's 157 to 169. For essential life-saving treatments like dialysis, many are forced to relocate to large urban centers like Winnipeg because there is no treatment available closer to home. Yet no medical transportation is available to our citizens who live in urban centers, even if those citizens are elders. We could talk about other program inadequacies and fundamental inequities with dental, vision, mental health, prescriptions, and medical supplies. And here's a few examples. Our citizens face long wait times and backlog services from the NIHB Vision Department. Providers, even on the approved list, are charging additional fees, but these monies cannot be reimbursed as they are above the approved rates. Providers should be required to make clients aware of this, as clients assume if they are on the approved list when it shouldn't be directly billed. And so they're taking on those additional costs. In order for us to secure long-term positive outcomes for our citizens and nations, these inadequate NIHB programs and services must be dismantled. I understand that the federal government acknowledges the gaps and the devastating results, but despite identifying this as a problem since at least 2016, there have been almost no improvements to date in 7 years. In conclusion, these are just some of the reasons that the Southern Chiefs organization is building a new First Nations health system that will provide better service and close the health gap between Anishinaabe and Dakota peoples and the rest of Canada. I thank you for your time and interest today and look forward to any questions.
Thank you, Grand Chief. We'll now proceed with questions, and we'll begin and these are 6-minute periods, and we'll begin with Mr. Shields.
Thank you, Mr. Chair. Thank you to the witnesses being here today. Good to see you back, Grand Chief Daniels. You got through a lot of things in a hurry, I recently visited with a person on Siksika and telling the stories of healthcare. And she told the story of an elder being in a hospital situation where language was the barrier, and simple things that they would do in a health center, they labeled the elder as difficult until someone was able to go to the hospital, translate the language so they could understand the difference in cultural practices. Can you relate in the sense of the challenges for elders in the health system?
You're asking me, right? We have communities that are 100% Anishinaabe Mowin. They speak the Ojibwe language, and absolutely they face those challenges. It's a daily occurrence, and we have to be able to address that in a way that is appropriate. I think that training is certainly a huge part of that, but you have to prepare, because many of our citizens who are transporting to these hospitals are aware that they will be there within a certain time and do have time to prepare. I know that there's a lot of stress right now in the health system, but that is not an excuse for being able to properly prepare for the admission of our citizens into these health facilities.
So in your opinion, is it the attending that goes with them? And as I understand the health system, if you don't have a navigator with me in my situation, if I'm the patient, I've got some challenges. So are you suggesting that would be, in a sense, the people traveling with them, the people that could act as their navigator in the health system, is the solution?
Well, I think that you have to take a combination of that. I think, yes, that can be a solution in a general sense, but in urgent situations, I think that the medical facility should be prepared already for those scenarios. And we already have sort of an idea of what the current population or the fluctuations in terms of health needs are within these facilities based on some of the history. That could give us a better idea on how to prepare our facilities for the admission of citizens.
Are you talking about Indigenous staffing then within the medical facilities, an increase?
I would talk about independent Indigenous staffing from these facilities, and we've already engaged in this in Jordan's Principle, for example, with the Children's Health Center here in Winnipeg.
And you have found positive results as you move forward on that?
I think that is going to create sort of some unique cultural interaction within the facility that would create a better outcome, because the task of our citizens within these institutions would be simply to ensure that our citizens are adequately dealt with and adequately understood in the event that they have to be there.
So as you've moved forward, in the sense, as you've moved forward, you're looking, and I've heard you before here speaking with the committee, and I think you have spoken very strongly in the sense of grassroots decision-making, understanding where the money is, but yet you're not able to control the outcomes from the spending. Is that still the case, what you would suggest with this?
Absolutely. I think that we are quite prepared to engage and to show the value, added value, that grassroots control, First Nations control over health can have an impact on the health system.
Expansion in the sense and the use of traditional Indigenous health and medicine, I would guess?
Absolutely. I think upstream thinking and health prevention is absolutely essential to changing that 11-year health expectancy gap, that rate of life expectancy.
How close in a sense of age as time is going on are you losing that information from your elders? How critical is that time frame to get that?
It's absolutely critical. The knowledge that is being passed down is less and less available to us. Our traditional healers, for example, have less and less ability to transfer that knowledge. We're in a state of crisis in many of our communities. It is quite difficult to create the environment for that education, which has been restricted from the education system itself. So there's been barriers in all aspects of our society for the transition of that knowledge.
Which ends up in denial and inconsistencies in the treatment because you're lacking in gap and you're lacking in knowledge.
And a loss of the enrichment of that knowledge in creating a better health system, not only for Indigenous people, but for all.
Right. Mr. Chair?
20 seconds.
Thank you, Mr. Chair. Thank you.
Thank you, Mr. Shields. And we're now going to go to Ms. Atwin. But just before, Chief, apparently they had a bit of trouble, the interpreters hearing you. Could you just check that your selected mic is the microphone for your headset? Just check that while we're waiting. But I'll turn it over to Ms. Atwin for 6 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for joining us today. I'm going to direct most of my questions towards Ms. Clark from the Native Women's Association of Canada. I'm a firm believer that NWAC has such institutional knowledge, has traditional knowledge, has that lived experience that we need to bring women's voices into this conversation more and more. So just in a general sense, I'm wondering, you're here today to testify, but are there other ways that NWAC is engaged on improvements around policy on the NAHB program?
Not on NIHB specifically, although I feel like we definitely have the capacity to be doing that. We have, as you were saying, we have really great knowledge embedded within the association, and we have really great leaders, and we're always grounded in culturally relevant, gender-based analysis. Everything is always trauma-informed, so that would be something we would welcome. However, we are not currently. Okay, excellent, thank you. And you highlighted something that's really important to me in particular, and as far as birthing services. And you highlighted an example of that as far as not being able to have an escort or additional family members outside of the escort, which I couldn't imagine, from a woman's perspective. Are there other specific barriers for women in particular, and also for perhaps gender diverse individuals? Is there difficulties in accessing gender affirming care, trans care? Is there expertise that's lacking in the NAHB system? So I'd love to hear more about that as well. Thank you for that question. I would say that, unfortunately, it is rife with layers of issues. Being someone who would be two-spirit, transgender, gender diverse, part of the 2S LGBTQIA+ community is already difficult, and if you layer on being Indigenous, that's only going to become more difficult. The Indigenous experience in healthcare has traditionally been extremely difficult, and then combining that with something that's already difficult as well would make it unimaginably almost impossible. I would also say that the idea of being two-spirit is something that is very foreign to most healthcare providers. They often associate that with being gay or being bisexual or something, and it's just a totally different thing. It's sacred, it's spiritual, and the understanding of that would would probably increase the ability to seek gender-affirming care. However, I think, especially if you're in a rural or remote community, it's going to be almost impossible to do that. In regards to your first comment about having access to birthing services, yeah, it's a decision between bringing your midwife and your doula or your child. And which child do you choose if you have several? Or do you bring your partner, or does your partner look after them? Or hopefully maybe there's elders in the community. There's just layers of having to decide who to be with you. Mr. Shields was speaking towards, having a navigator with you. Having a navigator is great, but so is having family. And having just one person is not enough. When I'm sure many folks in here have been around people who've been giving birth, and you're allowed to go to the hospital. It's easy. You drive over, you go, and you get to see the baby, and it's incredible. And that doesn't get to happen for the majority of Indigenous people who have family or who have birth and have family. They have to wait till they fly home. And I mean, flying is already traumatic for some folks, but never mind with a newborn. So it just, the layers and layers of barriers just continually keep coming up.
Thank you. And I looked at NWAC's website just recently, just to kind of brush up on some of the services, and I really like the section on knowing your rights and informing people about what that looks like and how accessing services. So I'm just wondering about how the ways that you communicate with Indigenous peoples across the country.
Sure, absolutely. So obviously, I'm really glad you've seen that. We have several websites that kind of, tell you what your rights are and what you're entitled to. Often when folks specifically related to NIHB, they're going to look for services. It's completely overwhelming, and typically they'll tell you to reach out to your local organization or your local association, because those are the people who are able to navigate it, because it's so complex. And when you're already, facing lots of other issues at home or layers of discrimination, it becomes impossible to try to figure out without someone to kind of walk you through it. In terms of what else we're doing at NWAC, we have again a really great team, as you pointed out earlier. And it's not my team, but I've got great coworkers who are working on how to know your rights, especially related to youth and gender equality. We have an initiative right now with, what does gender equality look like? Because that is ultimately a health issue. I can't speak to what my colleagues do, but yeah, for sure.
Thanks. And just with my remaining time, I'd love to focus on mental health and access to mental health care in particular. And I also noticed that you were part of creating a Heal the Healers workshop as well, because that's another critical piece, is ensuring that those that are giving help are also looking after their well-being. So I just, if you'd like to speak to mental health initiatives in particular.
Absolutely. Heal the Healers. I'm really glad you've seen that. That's something I'm quite proud of, to be honest. My team is incredible, and we engage with our elders and with our knowledge keepers and our traditional healers around the country. And we were able to develop a program that we were delivered through our Resiliency Lodge model that seeks to heal the people who are helping heal others. So typically, if you're having an issue, you might go seek out the help of an elder. Well, who's helping that elder? Typically not a lot of people. So we created a program, a 2-hour virtual program, and also an in-person day program that kind of scoots around NIHB, because you have predeterminations for most services. It takes forever to access them, and there aren't maximum times for waiting. It allows healing to take place within the culture that they are from, instead of within an institution that can be very scary. We also did one for community support workers and did a training so that they would know how to best deliver healthcare services to Indigenous women, girls, Two-Spirit, transgender, and gender diverse folks.
Excellent. Thank you.
Thank you. Thank you. Nous irons...
We'll now turn to Ms. Berube. You have 6 minutes. Thank you very much, Mr. Chairperson. I'd like to thank the witnesses for being here today, and also for the interpreters for the interpretation service. My question will be for all 3 witnesses. In this study, as in previous studies that this committee has undertaken on housing that was just completed, it's been mentioned on a number of occasions that health is omnipresent in the life of First Nations and Inuit peoples. And a healthy population is a foundation for a healthy life. Can you please explain the link that health has in the lives of Indigenous peoples with the community? Could you address the question to a particular witness? Well, the question is for all 3 witnesses. In that case,
Daniels, and then we'll go to Ms. Idlout, and then we'll go to Ms. Clark to answer that question. Chief Daniels.
Yes, thank you for that question. You know, it's quite simple actually. You know, if you're not healthy, you can't help people. It's you have to have a great deal of ability to not only have the mental capacity to provide direction, to provide knowledge, to transfer that knowledge on how to live healthy, and to participate in activities in the community that are healthy. Those are all, I think, important as an individual for you to sort of help and also mentor your families. You know, the families who are have those who are very healthy in the community who can support and are usually the sort of foundation, the person or the people who provide a great deal of support. They're that secondary support outside of primary families, aunts and uncles who are, you know, suffering from health issues. We see it a lot with diabetes. You know, the cancer rate's very high. It's a loss, you know, for us. For example, my mother right now is in the hospital, you know, and she's in and out because she has liver failure or liver disease, and it really weighs on not only myself but my brothers, my family, and we're always thinking of her. And she's still very young; she's not even 60 yet, and you know, and so it's sort of the livelihood and sort of the inability and sort of for the health system to provide alternatives or to provide sort of that extra support for her to have dealt with the health issues that, you know, are transferred as well. Diabetes is something that is very much preventable in our communities, but we continue to see skyrocketing rates that lead to amputations, that lead to failure in kidneys, and there's maybe not enough education around that. And I think that herself and others who are going through this, if they're able to overcome and able to manage, that's important for us, the younger population, to understand. And I think that it's not something that should be isolated to the health system. It's something that needs to be part of the education system overall.
Ms. Idlout, would you like to answer that question?
I lost connection for a bit, so I did not hear the question.
Okay, we'll repeat it.
Merci.
Could you please explain the tie that health has in the lives of Indigenous peoples with their communities, please?
Can I get an interpretation?
Okay, so you didn't hear that translated into English, Ms. Idlout?
No, I just turned it on.
Okay.
Sorry.
So the question was, what role does people's health, play in the lives of Indigenous communities? How important is it?
It really takes a toll on the whole family when someone is sick, because there's no hospitals in most northern communities, so most people have to fly out, and then we end up having to look for someone to be with that person out of town, leaving our family, our kids behind, and then being away for months at a time would be hard for everyone. I think that's all I have to say.
Thank you. And Ms. Clark, would you like to answer the question too?
Absolutely. Thank you for the question. I think it's impossible to speak about health without recognizing everything that goes into health. Health isn't just being healthy. It's having access to safe housing. It's having access to a safe environment. It's access to water. It's so many different things. In relation to community, when a community doesn't have those things, how can your health possibly thrive? And when, as Ms. Idlout was alluding to, when someone has to leave, that makes a big dent in the community. I was speaking before about how, you have to leave your children at home sometimes when you're just having a baby, something that, is pretty normal. And it disrupts not only your life, but the entire community's life. I would also like to highlight that health isn't as individualized for Indigenous folks typically. It's the community. And you thrive off of your community and what is going on in your community. So when one person is ill, the community rallies around. So it's not just, he or she or they have diabetes. It's, the whole community comes around. So I would say health is absolutely critical to creating a well-woven community.
Merci, Madame Bérubé. We'll now go to Ms. McPherson. Ms. McPherson, you have 6 minutes.
Thank you very much, Mr. Chair. And thank you for allowing me to participate in this committee meeting today. Thank you to the witnesses for their testimony. It's been very illuminating. Ms. Idlout, I'd like to ask you some questions if I could, because I'd like to get a bit of a sense of what it is like to be an escort for patients that is, providing that support. So could you just take a moment to tell us a little bit about how difficult it was being an escort for a patient?
Yes, I can. It gets really hard having to leave being an escort, especially having kids, leaving them behind and bringing the patient to the appointments, preparing them, for example, if they need surgery, it requires a lot of time. It gets really hard. And most times I wonder, why can't people that are receiving surgery have 2 escorts?
Mm-hmm. Thank you. And I, as somebody, I'm a mother, and we've heard testimony today about the impacts that would have, and I can only imagine how difficult it is for the patient to leave children behind, as you mentioned, and whatnot, but also for the escort to have to leave those children behind, sometimes for a very long period of time. But in addition to leaving our families behind, as an escort, can you talk about the experience of having to leave a job behind? Is that something that happens on a regular basis, or that has happened?
Yes, it has happened to me quite a few times. I work full-time. Most times I need to escort my grandmother when she's going for hospitals. And when I do escort her, since she is not my dependent, or she's not eligible to be my dependent, when I escort her, I have to go on leave without pay.
And you have to do that every single time that it comes in. So the impacts of escorts, of income on escorts, is very, very challenging then.
Yes, and I'm the only one in the house with a job, so that takes a huge toll on our income.
And are you ever, or are there examples where you are ever able to, where individuals are able to earn an income when they are an escort for patients?
No.
Okay, thank you. And roughly, could you tell me how many days or weeks or months were you away from home when you were an escort for your grandmother?
The longest
or other
was
family members?
3 weeks.
3 weeks at one time.
Yes. Most times it's 2 days to a week.
So for that 3 weeks, you had to take leave from your job as the sole employed person in your household. You had to take time away from your job without pay to support your grandmother.
Yes.
And can you tell us, if you're comfortable doing so, what the mental strain of that is, what the some of the additional difficulties of being an escort, in addition to the financial burden? If you could talk a little bit about perhaps the mental strain on you, on members of your household, on members of your community.
it gets to a point where I wonder, how will I feed my children? How will I pay the bills on time? And who's gonna look after them while I'm away? Like, it's really hard mentally to be away and to have to worry about who's gonna feed them, who's gonna take care of them, and who's going to put food on the table.
I'm sorry that you have to deal with that. We've heard from other testimony that every person has a right to the health care they require, and it should not come at the expense of their community, their family, their children, or their own well-being. So I'm very sorry that you have to endure that. I guess just the last thing I would say is, could you perhaps talk a little bit about what it would mean to you and to other members of your community if escorts could be paid for the work they do escorting their loved ones to treatment outside of the community?
Yes, it would. If escorts were to be paid, it would be less stressful wondering how we're going to get transportation, because most times if there are no drivers, we have to pay for our transportation. And if we were getting paid, we wouldn't worry about having food on the table so much, and being on leave without pay wouldn't be so scary.
Thank you for your testimony. It's very important. Thank you for taking the time to share your story with us. Mr. Chair, I will cede the remainder of my time.
Thank you, Ms. McPherson. We'll now begin a second round. We'll get through at least four, and we'll start. I have here Mr. Vidal for 5 minutes.
Thank you, Mr. Chair. I want to thank all the witnesses as well today for your testimony and sharing kind of with honest concern some of the things you face. Grand Chief Daniels, I want to talk with you for a couple minutes about your navigator position. I was looking on the website of your organization and looking at the work that navigator does. And back on May 3rd, we had a Dr. James McCocas. He's a Plains Cree family physician here, and he shared that to get many services covered through the NHIB, that there had to be a fair amount of advocacy on his part on behalf of patients. So my expectation is that your community members have had to face similar situations. You talked about inconsistent application of policies, and if I'm making the right connections, that's kind of where your navigator position comes in. So I guess my question for you would be, would you share some of the challenges that are faced in kind of if it's the bureaucracy or the process, and how your navigator position has been used to address some of those?
The navigator has done a lot of, obviously advocacy and navigation within the NIHB, trying to find sort of solutions to some of the problems that our citizens are facing. And so it's been a tremendous help, I think, in connecting the dots and providing that support for many of our citizens. It is one position in a system of hundreds of thousands in many instances. And so it is a Monday to Friday, 9 to 5 position for one person. And so the impact, in relative terms is can be measured. I don't have the sort of numbers in front of me in terms of the day-to-day, because I haven't been briefed specifically on that. But in terms of what has the impact been, or what is the sort of client inflow in that? But I can say that it is a relatively small part of sort of all of the sort of existing problems that are outside of that, in terms of how NIHB approves and not approves and communicates and connects with communities and services that are in communities on reserve. And in addition, I don't think that there is as much sort of a presence in the off reserve, except for that they would provide, I think, some of the expenses or the approvals of costs associated with health.
Thank you. I was going to go down that road a little bit further, but just in the matter of time I have left, I'm going to switch topics a little bit and just go to something else that you referred to. And it's because there's a link to things in my writing. You talked about the issue with medical taxis and some of the costs associated. I mean, we've seen some really significant numbers in the context of fuel prices and inflation. And what I'm hearing in my writing is that some of these medical taxi businesses are actually going to cease to operate, and that's going to create a huge issue in my northern Saskatchewan writing. I'm just curious if you've heard those kinds of concerns for the First Nations that you serve as well, that there's some risk of that becoming a real issue.
Absolutely. What's going on is huge in terms of what the additional costs are. Food security, it's huge problems going on and concerns. I mean, even our health, our nurses have been restricted from the north in emergencies only as a result of the high needs of nurses in the urban areas, and it just reflects sort of how First Nations communities are not the priority here. It is really focused on the urban areas in terms of how health is managed in the region. And it's for those reasons that we need independence from these provincial systems in some ways, because we have to take care of ourselves. We had traveled internationally to create a value-added model in partnership with Cuba at one time. And we're looking to provide healthcare service experts for our communities, and had also had the ability to train our citizens within the health system over there. And that could have created some, I think, solutions to the problems that we experienced with COVID, although we weren't given that ability. We weren't given that opportunity, and we were shipping people out of Manitoba because the system wasn't able to take on, the crisis. And so, and now we're seeing another example of this here in Manitoba, where our nurses are being taken away. And so, if in a case like that, where we're not being prioritized, it's quite simple that the system is not putting First Nations in the place where we need to be. There's already an 11-year life expectancy gap that is terrible for our elders who need to be passing on that knowledge. And I mean, we just need to create our own system. It needs to be independent. We need to have our health experts looking out for ourselves, and until there's trust built. But I don't know, it's decades and decades of a culture that has not been built to serve the needs and interests of Indigenous people.
Thank you, Mr. Vidal. We'll now go to Mr. Baptiste for 5 minutes.
Thank you, Mr. Chair, and always glad to hear from you, Grand Chief Daniels. And, as we go through this study, one of the things that keeps kind of popping in my mind is that a lot of the challenges that are being faced are the result of someone besides First Nations are deciding for First Nations how they should manage their health system, what to approve, what not to approve, not based on that community's needs or that community's cultural values, but rather what a bureaucrat has decided should be appropriate for our communities. And I'm wondering, with the successes I've seen around nations taking on their own jurisdiction, whether it be education, whether it be health, is that part of the solution, Grand Chief, that we need to look at, is giving nations the ability to take over jurisdiction over their own health with bilateral agreements between the federal government and those nations, as we've seen in really good examples of how that's happened, including MK out in Nova Scotia. I wonder if you could speak to that a bit.
I think that's the only solution at this point. And the reason for that is because the life expectancy gap is not changing right now. It's not changing in the trajectory. It's actually getting worse. And we need to be innovative in terms of utilizing the very limited amount of health resources that's already allocated, and trying to add value to that. And that's why we've tried to look internationally. That's why it's important for us to build internal capacity for ourselves, and not be tied to a system that is going to look after its own and not really necessarily look after us. It's not a system that has put First Nations interests in at the top of the list. We're at the margins of every socio-economic indicator that you can point to in this society. And I mean, that just reflects, I think, from anybody who has independence in terms of their political, observations of health. I think that it's important to understand that. And It's not going to simply change or tweak because we add a few First Nations people in there. We need to be at the nucleus of decision making and have control over that, so we can hire the best minds and the most seasoned sort of veterans in health who can take an approach that respects the jurisdiction, respects First Nations patients, and does everything that it can to maximize that very limited amount of resources. We understand that's very limited amount. So we need to be able to deal with these things in a way that is going to maximize that impact. And that's what we want to do.
Can I ask you, do you know of any examples where this is working, for where nations have taken over jurisdiction of health? I'm not aware of one, and so I just thought I'd ask you.
Well, you'd have to go outside of Canada. Let's look at Alaska, where they're running the whole system over there with their with the school, and I think that has been the best example for us. I mean, we went there, we saw it. I think that you've seen a patient-focused model where it is about the patient, it's about the client, and it was fulsome. It's not simply just the doctor itself. It's all aspects of one's health, right from the day that they're born all the way until their death. It's the same sort of health team or unit that monitors and provides that health service. So, we are looking at those sorts of models to try to maximize and create a health system here in Manitoba.
Thank you, Grand Chief. I have a question for Ms. Clark. You said you had some detailed recommendations. I'm wondering if you could speak to the missing and murdered Indigenous women's and girls calls to justice, or the TRC calls to action. In what recommendations you would make for us as a committee to move forward on that? You said you had some detailed recommendations at the end of your study. If you could just name off a few. I know we only have about a minute, so could you give me the most pressing ones?
For NIHB?
Yes.
I specifically related to MMIWG?
If there are any that comes to mind, I don't want to put you on the spot because I know there's 231 calls to justice and 90 some calls to action. But if you could, from the NWAC perspective, give us what are the pressing recommendations that you think we should move forward on as a committee?
I don't think I can fruitfully answer that question in a minute.
You do have some time, and you can put it in writing at a future date. I know it's a lot to ask, but as we try to get a really good study moving forward, and we want to have good recommendations moving forward to our government, if you could provide those and give it some thought, I think that would be tremendously helpful from NWAC, as well as make sure to tell President Whitman I said hi.
Absolutely, will do.
Okay.
Thank you very much, Mr. Baptiste. On va aller à Madame Bérubé.
Ms. Bérubé, 2.5 minutes, please. Thank you very much, Mr. Chairperson. We know full well that one of the underlying topics in a number of studies is remoteness and isolation. When you're remote, like we are in northern Canada and like in my riding, we know that the pool of professionals that employers have access to has diminished significantly. Do you have any recommendations, and I'll ask the question of all three witnesses, Mr. Chairperson, do you have any recommendations as to access to medical transportation, and also how can we cut red tape and bureaucracy?
Ms. Clark, then go to Grand Chief Daniels, and then to Ms. Seidlout. If you would like, fairly succinct, we only have a couple of minutes.
Absolutely. I think one of the easiest ways that we could cut red tape and reduce the time that goes into medical transportation would be flexibility in arrangements and having less levels of bureaucracy involved. And as Grand Chief was speaking to, devolving it from what it is right now and putting it in the hands of Indigenous folks. They know what they need. We should ask them. We should let them, be able to decide how and what transportation looks like. Thank you.
Grand Chief?
I would say that you transfer jurisdiction and allow First Nations to make the decisions and to find alternative ways to create and maximize the use of that funding.
Thank you. And Ms. Seidlout?
I'm sorry, I don't know how to answer this question.
Alors, c'était pour rendre...
Well, the issue was making transportation more effective. If I might.
It was if you have any recommendations for how to make the transportation of patients from their homes to medical centers, how to make that more efficient. You've spoken a lot about escorts. Are there other points that you would like to bring up?
No.
Elle a dit non.
She has said no, that she has nothing further to add.
Ms. McPherson, you have 2.5 minutes.
Thank you, Mr. Chair. I would like to ask a question of Grand Chief Daniels and Ms. Clark, if I could, because I know I have a very short amount of time. Very clearly, would the mental well-being of Indigenous peoples improve if elders and traditional counselors were incorporated into the NIHB program, similarly to how other service providers are incorporated?
I wouldn't go down that route, only simply because you're sort of trying to put a brown face on a system that is failing already. I think it needs to be controlled by First Nations leaders and First Nations experts. And I think that's really the only way. We will have our elders with us the whole way. It's always been done that way. We always speak and start in a good way. And so I would not be in favor of that process. I think that's the process that's been done for the last 20, 30, 40, 50 years.
Okay, thank you. Ms. Clark?
And I would say that, echoing, what Grand Chief said, starting in a good way is the best way, but if you cannot start in a good way, which I don't believe the health of First Nations has been started in a good way at the hands of the government, if we can make these small steps, they will lead to improvements in health. And having your traditional people, knowledge, ways of knowing incorporated within your healthcare is bound to lead to increased mental health for everyone around. We're actually currently looking into this exact topic at NWAC and, put some data behind it. And yeah.
So, and I guess maybe Miss Clark, just for your last comment, we do have about 30 seconds more. So if you'd like to reiterate any other learnings that you didn't have an opportunity to say earlier, that would be great.
Absolutely. I think
you get the last 30 seconds.
Absolutely. I think that an area that has been really overlooked within NIHB is utilization of pharmacists and using not only, obviously they're dispensing medications, but they can treat minor ailments. And minor ailments can often lead to larger ailments if you don't get them treated quickly. Pharmacists are the most accessible healthcare providers within the country. And significantly more easy to access than doctors often. So if we can utilize pharmacists in a better capacity, I think that could, be one drop in the bucket of getting towards better health for Indigenous folks. Thank you.
Thank you so much.
Thank you very much. This brings us to the end of our panel. I would like to, on behalf of the committee, thank Ms. Idlout, Ms. Clark, and Grand Chief Jerry Daniels. Thank you for your opening remarks and your testimony on this very important subject. And we will now, in fact, engage in the process of putting together a report. You were the last witnesses that we've heard. And we very much appreciate you taking the time. We apologize for starting an hour late, but we very much appreciated your testimony. So thank you very much. And with that, colleagues, we will suspend so that we can go in camera.